Hello, very good evening. I welcome you all to Thursday webinars by CCI, and it has been going since 2019. Today we will be discussing on lymph node tuberculosis. I am Dr. Mahesh Jansari, and presently I'm working as an associate professor at AIIMS Kalyani. So let's start the session. Tuberculosis has been troubling the mankind for thousands of years, and it was #1 infectious killer till COVID arrived in 2019. TB infects almost every organ system except hair and nail. And as per the WHO report 2021, TB is the 13th leading cause of death and second most infectious killer after COVID. In 2021, almost 1.6 crore people contracted tuberculosis and 16 lakh of which died. Tuberculosis has been classified into pulmonary and extrapulmonary form, and extrapulmonary tuberculosis accounts for 20% of all cases. And amongst these 20% cases, lymph node is the most common organ. TB lymphadenopathy is almost seen in 33% of these extrapulmonary cases. Now let's discuss today to conquer the tuberculosis. So for today's wonderful discussion, we have Dr. Vikas Oswal. So I'll begin by introducing Dr. Vikas Oswal.
Hello, Dr. Mahesh. Thank you.
Dr. Vikas Oswal is a case consultant and is a national NTP trainer, is a subcommittee member, and is a national technical expert in CTD. He is a pioneer in private-public NGO partnership and motivated almost all the private chest physicians in Mumbai to join and work along with the public sector, and have played a major role in their collaboration with public sector. He is a chairperson of 2 Dotsburg sites in Mumbai, and till date he has registered and started treatment for more than 9,800 plus drug-resistant tuberculosis since 2013. He has multiple publications and multiple things to his credit. So I welcome Dr. Vikas. Next we have Dr. Shilpi Dosi. She is a consultant pathologist from Indore, and presently she is working at Kokilaben Dhirubhai Ambani Hospital, Indore. She has an experience of almost 11 years, and she has areas of interest like oncosurgical and lung pathology. One more thing to mention, she has done a pulmonary pathology course by Mayo Clinics, and she has multiple publications to her clinic. So I welcome Dr. Shilpi Dosi. We have Dr. Abhijit Kumar. He's an ENT surgeon, and he's a consultant otolaryngologist and head neck surgeon, Tata Men Hospital, Jamshedpur, Jharkhand. He has 15 years of experience in various high-volume surgical centers. He has a special areas of interest like endoscopic skull-based surgery, head and neck cancer surgeries, and cochlear implant and implantable hearing aids. I welcome Dr. Abhijit Kumar.
Thank you so much.
We have Dr. Ruby Joseph. She has done her DNB in pulmonary medicine from Lilavati Hospital in Mumbai. She has completed International Sleep Research Training Program Fellowship by World Sleep Society from St. John's Hospital, Bangalore. She has presented multiple posters at national and international conferences. She had been faculty at World Sleep Academy by World Sleep Society. So I welcome Dr. Ruby Joseph. We have Dr. Joydeep Ganguly. He's a consultant pulmonologist and certified allergy specialist in Berhampur, West Bengal. He was ex-assistant professor at Sikkim Manipal Institute of Medical Sciences, Gangtok. He started fiber optic bronchoscopy for very first time in Murshidabad and neighboring 3 districts. He has the only chest clinic in mid-West Bengal having facilities of DLCO, FILO, and iOS. He is experienced in managing DRTB center and trained under IVATLD. So I welcome Dr. Joydeep Ganguly.
Thank you very much.
So let's start today's discussion. So what is lymphadenopathy? Lymphadenopathy is any abnormal in either size, consistency, or number of lymph nodes. There are different terms used for lymphadenopathy like lymphadenopathy, lymphadenitis. Sometimes these are used synonymously with each other. However, these are little different. So what is lymphadenitis? It is inflammation of the lymph node. And then lymphadenopathy, it is a broad term to include both inflammatory as well as non-inflammatory causes. And lymphangitis, as you all know, it's an inflammation of lymphatic vessels. Many a times, scrofula word has also been used for lymph nodes. So specifically, it is a lymphadenopathy which affects the lymph nodes of neck, usually in cervical region, and it's of infectious etiology. It is called the scrofula. So today, now we'll start our discussion on lymph node tuberculosis. So my first question is for Dr. Vikas Oswal. Sir, let us know what is the epidemiology of lymph node tuberculosis in adults and pediatric population in short.
Yeah. You already rightly mentioned, tuberculosis. It's really bad right now that every year about 10 million of people develop TB and 1.6 million people die of it. That's very true. As per our latest figures from NTEP, around 15 to 20% in India, where, urban places in India, they have 25 to 28% of TB lymph nodes. Whereas, if you see somewhere in the places where the diagnosis is really high, the incidence would be more higher over there, probably 35 to 40%. So in rural area, if you see, there is 25 to 38%, whereas in urban areas of India, there is 35 to 40%. So this probably difference is because of the good diagnosis, better diagnosis, availability of all the laboratories over there. Ratio, if you see EPTB and PTB, initially the ratio was really, just two cases is to 10 cases. Like you used to just find 2 cases of TB, EPTB compared to 10 cases of PTB. But nowadays the ratio has really gone up. The ratio is like, you can say 30% you will find EPTB, and especially out of that 35 to 40% would be cervical lymph nodes. This is what probably we are seeing. And more of them, out of these, there is male preponderance more compared to females. Younger male age group is really having a high amount of this thing. And if you talk about children, in children that is less than 14 years of age, 4.4 cases per 1,000 cases, you may find a lymphadenitis right now. And 30 to 40% of these are lymphadenitis. So somewhere these cases of lymph nodes have gone up. Maybe the diagnosis have also improved, and that would be one of the reasons over there.
Okay, so as Dr. Vikas, you have very clearly mentioned that EPTB comprises almost 20% of all tuberculosis cases, but now the figure has jumped to 30%, almost 1/3 of every EPTB case. We find one EPTB case, and of this EPTB case, 35% are lymph node tuberculosis. Worldwide, it has been described that there is a female preponderance, but actually in India, it's male preponderance. There is one study by Mr. Srivastav et al., and he found that there is a male predominance in Indian geography. So my next...
there would be a variations in immune-related factors probably, and interleukin-10, which may lead to this both gender preponderance, where you will find more in males compared to females.
Yes. And... as per the RNTCP 2014 report, a total estimated incidence of lymph node TB was around 30 cases per 1 lakh population in India. So that's a huge number. If we extrapolate the figure to around 130 crore population. So, Dr. Ruby Joseph, can you please let us know what are the risk factors for lymph node tuberculosis?
It could be patients who are immunocompromised to begin with. HIV patients, people living with HIV/AIDS complex. Diabetes increases the risk to about 3-fold. Diabetes have a 3-fold higher risk of developing lymph node TB. Renal insufficiency. Homelessness, as in these people are more prone for high-risk behavior, poor nutrition, poor ventilation in the shelters that they have, and IV drug abuse. These people are more prone to, in that way, homelessness and alcohol abuse. These are the few risk factors. And of course, contact with a positive TB patient who is there. So those are the risk factors for lymph node.
Dr. Vikas, would you like to add something to?
No, I think that's fine. More of upper respiratory tract infections, earache, coryza, she's already covered those things. And conjunctivitis. These are the commonest risk factors, probably, some of the additional causative factors which may lead to lymphadenitis.
Okay. So actually, lymphadenitis in children, the most common cause is viral infection. And as we go to adult population, as Dr. Dubey has mentioned, HIV, malnourishment, diabetes, this increases the risk of contracting the tuberculosis. So Dr. Joydeep.
Yes.
So what is the symptomatology of tuberculosis apart from swelling and constitutional TB symptoms you see in your practice?
Yes. So as my professor, Dr. Shobna Kundu has said, that show me a department and I will show you a symptom of a TB patient. So we know that TB is ubiquitous in each of the departments. So it started with the chest symptom, we have cough, the classical cough for more than 2 to 3 weeks. Then we can have hemoptysis. We can have breathlessness due to inextensive pulmonary tuberculosis or pneumothorax or pleural effusion. Then in miliary TB, there may not be any symptom. It can be asymptomatic in about 4.9% of patients. It can present with a respiratory failure in case of enterobronchial tuberculosis or any other cases where there is a severe infection with TB. Then chest pain, hoarseness of voice due to laryngeal TB can be seen. In cardio patient, there may be chest pain, shortness of breath, orthopnea, and ankle edema can be present due to pericardial effusion. Also, in gastrointestinal TB, there may be abdominal pain, there may be nausea, vomiting, constipation, subacute intestinal obstruction-like symptom, and esophageal TB may be presented with a dysphagia or rhinophagia. We go to neurological TB where may present with a multitude of symptoms with a subacute onset like headache, nausea, vomiting. We can have focal or generalized seizures, cranial nerve palsy, especially 6 nerve palsy is very common and specific for this tuberculosis in the brain. And we can have partial or complete loss of vision. Also, we can have TB spine where there is a localized back pain, paresthesias, referred pain, and bladder and bowel disturbances may be present. There may be localized swelling in the spines are there. Also, we can have skin tuberculosis like miliary lesions, lupus vulgaris. We can have genitourinary tuberculosis like we can have this common irritative voiding symptom. Also, hematuria, flank plane, pyorrhea may be present. And yes, I can go on, but you know how this is. Every system there is a symptom of tuberculosis can be present. Thank you.
Okay. So as I mentioned when I began my talk, the TB can affect each and every organ except the hair and nail. So as you clearly described all the symptoms of tuberculosis, so of the lymph node tuberculosis, the most common symptom which patient presents with is the swelling, and it is in cervical region. Also, the symptoms may range. Specific symptoms patients can have by the compression effect of lymph node on the adjacent structures, and patient can have a non-specific constitutional systemic symptoms of tuberculosis. And classical lymph node patient is a young person who is immunocompetent, presents with a localized cervical swelling which gradually increases in size. Usually it is more than 1 centimeter. On palpation, it is matted, firm, and without any treatment, in due course of time, it may become boggy. And this bogginess can lead to formation of fistula after releasing the cheesy gaseous material from the lymph node. So this is what is the classical lymph node tuberculosis patient presents with.
Yes.
So next, then I'll ask Dr. Abhijit, what are the common group of lymph node a physician should examine during his clinical examination?
Can you just repeat the question, Dr. Mahesh?
What are common group of lymph node a physician should examine during his clinical examination?
Right. So I was just listening to the discussion. So in my experience, what I've seen is that, in extrapulmonary Koch, especially cervical tuberculosis, generally it presents as, either a single discrete lymph node or sometimes it presents as matted nodes. So during clinical examination, generally we divide the deep cervical group of nodes as per the classification of Otolaryngologists Association of America into 6 groups, cervical lymph node groups. So there is 1, 2, 3, 4, and 5, and 6. So 1 is basically submental and submandibular that has been divided into 1A and 1B. based on the digastric belly, the anterior belly of digastric. Level 2 is basically an area that extends from the skull base to the level of the hyoid. And it has been further divided into 2A and 2B based on the vertical segment of the spinal accessory nerve. Level 2 is where you find the largest lymph node, jugulodigastric lymph node. Level 3 nodes are generally between the hyoid and the cricoid, and the jugulo-omohyoid group of node is found in level 3. Level 4 are nodes that are found below the level of the cricoid area to the level of the clavicle, and generally it includes the node of Virchow, which is the anterior group of supraclavicular node. Level 5 is basically posterior triangle node that has been divided into two, 5A and 5B, based on the level of, again, cricoid, and also the superficial segment of the spinal accessory nerve. And level 6 is the level that is extending from the hyoid to the suprasternal notch, and it basically includes nodes from pretracheal, paratracheal, the Delphian node, and nodes along the recurrent laryngeal nerve. So clinical examination should include examination of all these levels. And most commonly, what I have found is we find nodes either in the supraclavicular or super level 2 nodes, or sometimes you will find multiple matted nodes in the level 5. These are the common sites that I have found nodes.
So, as Dr. Abhijit has mentioned, whenever a physician examines physically a patient, he should target looking at the cervical group of lymph nodes. So I'll summarize that. He has mentioned about the level 1, that is 1A submental, level 1B submandibular, level 2, 3, 4 upper jugular, mid jugular, lower jugular, level 5 posterior triangle lymph nodes, and level 6 is anterior compartment lymph node, which is the most commonly supraclavicular lymph node. So other group of lymph nodes which one should examine is axillary group of lymph node, then inguinal group of lymph node, and sometimes very occasionally it's a popliteal or epitrochlear lymph node. I have never encountered a epitrochlear lymph node in my life, but it has been described specifically for syphilis.
So, Mahesh, I would like to just add here we're saying the supraclavicular nodes. So generally these supraclavicular nodes are either level 4 or you'll find level 5. The anterior group is the central compartment that lies between the anterior border of sternocleidomastoid, right and left.
Okay. So, Dr. Vikas, anything specific comment about the lymph node tuberculosis in pediatric population?
In pediatric population, usually, the lymph node lymphadenitis is very much common. So it's not necessary that always if there is a swollen lymph node over there, if there's lymphadenitis, that means it's infected. It is not necessary. You need to keep something in mind that 2 centimeters in the neck, 1 centimeter in axilla, and 1.5 centimeters of inguinal region lymph nodes are usually considered to be normal size for children, pediatric populations. So such lymph node size, if you find in adults, maybe you may suspect and go ahead with invasive procedure and diagnose it. But if it is in children, probably you may still wait and watch, and then still if the patient is symptomatic, you may then maybe think of certain infective cause for it. The same way, I would definitely like to palpate all the cervical regions, supraclavicular regions, the axillary regions in a similar way, same as in adult. The difference is only of the size. It is probably normal in cases of children compared to adults. That is the only difference. But yes, do not forget and always keep in mind that we do have 8%, sometimes 8% of even childhood lymphomas, which is very rare. But if you find something, a node which is probably a bigger than 2 centimeter or 3 centimeter size, please do not fail to just go and invasive it, and probably you may not miss a diagnosis of lymphomas, which is common cause of lymphadenitis in children probably. Both Hodgkin's or non-Hodgkin's, both of these may cause lymphadenitis. Other common causes Dr. Ruby has already covered in case of children: upper respiratory tract infections, coryza, sore throat, conjunctivitis, even many times the dandruff, scaly this thing may also lead to posterior cervical lymphadenitis. So just treat the underlying respiratory cause, and probably these lymph nodes may just go away. But if it is not, then you may definitely go ahead and put a needle inside and just prove it. Very much important.
Yes, yes. As you have clearly mentioned, the most common cause of lymphadenopathy in children is viral infection.
Yes.
Lymph node is more than 2 centimeter persistent. We must look for the lymphomas. And one thing I would like to mention that as a part of Bohn's complex in children, there is a small parenchymal lesion. However, there is a big lymph node. And this big lymph node sometimes can compress the bronchus and cause a collapse and further sequelae. So that is very important. So Dr. Abhijit, just let us know our audience that what is the normal size of lymph node and what is abnormal size, and which group of lymph node is commonly involved in tuberculosis.
Yeah. So basically, in clinical practice that we see, so we have read in our textbooks the largest lymph node in the neck is the jugulo-digastric lymph node. So up to 1.5 centimeter jugulo-digastric nodes are quite considered normal. You will also find up to 10 millimeter, 12 millimeter, maybe even 1.5 centimeter also nodes in submandibular areas. It may be secondary to, presence of dental caries or oral infections or, some ulcerations in the oral cavity. So that is actually very common. So in level 2, or, one of the clinical dictums that we follow. So our finger can palpate a lymph node of about 10 millimeter in size. More than 10, it has to be bigger than 10 millimeters for our, fingers to get it. So we can take it that most of the lymph nodes in the neck are less than 10 millimeter in size. And we know that there are more than 300 groups of lymph nodes, 300 lymph nodes in the neck. And, a node has to be larger than 10 millimeter for us to palpate, to clinically feel it. Most commonly that I have seen, we have seen the textbooks. There are various presentations for cervical tuberculosis. And, it can be an isolated lymph node presenting at any of the levels, or it can be presenting as multiple matted lymph nodes, or it can be multiple discrete lymph nodes also. And what I've commonly seen, as per theory, the commonest level that is affected is the supraclavicular node in extrapulmonary tuberculosis. Whereas in clinical practice, many times we have observed, discrete nodes at level 2 and level 5. That's what I feel are, commonly seen in our population. That's what I have seen. And very rarely I have seen level 2 nodes. Level 1, 1A, 1B nodes. But most commonly I have seen, either 2, 5 or the supraclavicular group of nodes.
Okay. So I'll just summarize that cervical lymph node should be sub-centimeter. If up to 1.5 centimeter of upper jugulo-digastric node is also normal.
Jugulo-digastric nodes, yeah.
Plus to mention about the size that up to 1.5 to 2 centimeter of inguinal lymph node is a normal size lymph node. Any lymph node which is more than 0.5 centimeter in epitropial region is abnormal. Any other lymph node which is more than 1 centimeter, we should be cautious and hunt for the underlying etiology. Plus, any lymph node which is in supraclavicular region, we must keep that patient under observation. So, Dr. Ruby Joseph, please let us know how do you approach such patients of lymphadenopathy?
When a patient comes to us with a swelling, basically that is the complaint that they come that they notice the swelling. So we could go about with an algorithmic approach. First of all, the history is most important to know when did it start, how was the progress of the swelling, and for that we should remember the causes of lymphadenopathy. It could be remembered with an acronym MIAMI: malignancy, infectious, autoimmune, miscellaneous or unusual, and iatrogenic. So just enumerating just 2 or 3 of each. Malignancy could be lymphoma, leukemia, Kaposi sarcoma, skin neoplasms. Infection could be TB. HIV infection per se could cause generalized lymphadenopathy. Other bacterial infections, fungal infections, viral infections like cat scratch disease, brucellosis, all these can cause generalized lymphadenopathy. Apart from that, autoimmune, SLE, rheumatoid arthritis, Sjogren's and dermatomyositis, and Coming to miscellaneous or unusual, like Kikuchi's disease, Kimura's disease, Kawasaki, and infectious serum sickness and drugs. There are drugs that can cause, so a history like if the patient is on phenytoin or allopurinol. So this history is very important, especially to localize what could be the cause of it, especially if they say that they had an exposure to a cat scratch, then our focus goes towards that. If they have an exposure towards uncooked meat and milk, raw milk, then our focus goes towards brucella, so that we can direct our investigations to that. Next would be like Dr. Abhijit sir told regarding the physical examination. So each node, one must know what is the location of the node to know that which is the draining part, to look for whether it's a localized disease or a generalized disease. Now, if it's a localized lymphadenopathy, look for the local causes of it, depending upon the draining area. Suppose it's a submandibular, look for oral lesions. It's a preauricular, look for scalp lesions. So local look is very important. The size of the node, as sir told, is more than 1 centimeter is unusual. Epitrochlea more than 0.5 mm needs evaluation. The consistency of the node, which if it's firm, matted, or if it's very hard, then hard goes towards malignancy. So once we complete the examination, our diagnosis narrows down whether it's probably malignancy or non-malignancy. And then our investigations can be directed towards it. So baseline, when we do a blood investigation, a CBC with a differential, HIV screening, HBsAg, RPR, all these are blood tests that needs to be done. MAN2 per se will not diagnose a lymph node TB, but an energy will be essential to differentiate between lymph node TB and lymphoma or sarcoid, because these are also important causes of lymphadenopathy. So MAN2 in that way is important. If it's a MAN2 negative, then we think that, okay, it could be probably a lymphoma or a sarcoid, so that our direction can go towards that. Radiologically, when we come, after we have come down and narrowed it down, before we go to tissue diagnosis, which is the gold standard before we start off any treatment, a radiological examination. So first of all, a chest X-ray to look for any lung lesions are there, parenchymal lesions. An X-ray neck would give you an idea whether it's a cystic lesion or and then we go for an ultrasound neck, which is very important to differentiate and delineate from the surrounding vascular structures. So an ultrasound with a color Doppler would be very efficient in helping us to find out which is the whether it is a node, whether it's a matted lymph node or a vascular structure before we go in and put in a needle. So that is very important. In case of unexplained lymphadenopathy, which is not explained after we have gone through all this meticulous process, then we go in for an FDG PET, which is only to give us a clue at the end. Like if you're not getting a clue of why this patient is having such a lymphadenopathy, it would just give us of the extent of the disease, of the SUV uptake, which is the most accessible and the high yielding node from which we can take a sample. So that won't give you a diagnosis, that will give you a marker towards where to take the biopsy from. And CT with contrast will help in looking for abdominal and intrathoracic lymph nodes. So those are the tests that are required. And then, of course, tissue diagnosis is the gold standard for diagnosing the lymph node.
Okay. So, you have very beautifully told all of us that how to approach a patient with lymphadenopathy by remembering acronym MAMI. So MAMI, you mentioned M for malignancy, I for infection, A for autoimmune diseases, M for miscellaneous, and last I for?
Iatrogenic.
Iatrogenic, okay.
From the drugs that we give or serum sickness that would be possible.
And history is a gold standard for to approach any disease. Then we will palpate the lymph node, we'll see what is the size, what is the number, what are the locations of lymph node, plus what is the consistency. If it is hard, then we must think about the malignancy. Plus, as per the location of the lymph node, we should find out the draining area of lymph node to narrow down our diagnosis. After this, usually we go for the routine blood investigation, but never forget to go for the HIV. Then one-tooth tuberculosis, which is very useful in sarcoidosis. Then radiology, chest X-ray. If in radiology, if you want to look for a mediastinal lymph nodes, then you will require a CT thorax, SOS contrast, and USG neck to look the proximity to nearby structures. If PET CT in cases of occult tuberculosis, and then tissue diagnosis is a gold standard. So that's very beautifully explained by you, ma'am. So Dr. Joydeep, will you please tell all of us that what are the differential diagnosis of lymph nodes which you think when you come across a patient of lymphadenopathy?
Yes. Whenever we came across a diagnosis of lymphadenopathy, and we should have different patient profile like age and previous medical history. So we need to identify some of the main features. Like it can be an infectious disease. So infectious causes may be viral. That is very common in children, like infectious mononucleosis syndrome with EBV or CMV. We can have infectious hepatitis, herpes simplex, herpes virus 6, HIV is a common cause, like rubella, measles, and adenovirus are also common viral causes are there. Regarding bacterial causes, there may be streptococcal and staphylococcal infection, cat scratch disease, brucellosis, tularemia, plague, melioidosis. There are lots of number of cases. Also, microbacterium tuberculosis and atypical mycobacteria NTM infections are very common. Also, primary and secondary syphilis is an important cause. Also, less common causes are diphtheria, leprosy, and Bartonella. Regarding fungal, there are dimorphic endemic fungus like histoplasmosis, coccidiomycosis, and paracoccidiomycosis, which are not common in normal patients, but immunocompromised patients, they can be a cause for lymphadenopathy. Regarding chlamydial infection, lymphodenoma venereum is a well-known cause of STD, and with trachoma can also be a cause. Also, in the parasitic diseases, toxoplasmosis, leishmaniasis, trypanosomiasis, and filariasis are important cause of lymphadenopathy. Regarding rickettsial diseases, scrap typhus, rickettsial pox, and Q fever are very common. Regarding immunological disease, we have a lot of autoimmune diseases or connective diseases that present with a lymphadenopathy or present lymphadenopathy as features like rheumatoid arthritis, juvenile RA, mixed connective disease like SLE. We can have dermatomyositis, Sjogren syndrome, also serum sickness. Regarding drugs, as Ruby already said, the artery causes, we can have diphenylhydrantoin or antiepileptic drugs. We can have hydralazine. We can have allopurinol, primidone, gold, or carbamazepine as a cause of drug-induced lymphadenopathy. Also, there are some lesser common causes like primary biliary cirrhosis. We can have graft versus source disease, silicon-associated. Also, autoimmune lymphoproliferative syndrome can be present. There are some storage disease we can present with the lymphadenopathy, like Koch's disease, Niemann-Pick disease. Some malignancy like lymphoma, like Hodgkin's disease, non-Hodgkin's disease, acute or chronic lymphocytic leukemia, hairy-cell leukemia, all can present with this kind of lymphadenopathy. There are some rare diseases which are not common, but we should know at least the name, like Castleman disease, that is a giant lymph node hyperplasia, the sarcoidosis that is very common, lymphadenopathy, cysticercosis, necrotizing lymphadenitis, or Koch's disease. We can have histoacidic. So there are lots are common. Also, one typical endemic disease is familial Mediterranean fever, with also present with lymphadenopathy. So these are the main common causes we can think of as a differential diagnosis of lymphadenopathy. Maybe sorry.
List of differences.
Yes.
So while mentioning the differences, you mentioned about the NTM also. So then I'll ask Dr. Vikas, what is your take of NTM infection in the differentials of lymphadenopathy?
NTM, basically, they are nothing but the isolates, of AFB other than MTBs, that is, other than Mycobacterium tuberculosis. So NTM can be isolated from a variety of environmental sources, including like water, maybe food products, or domestic animals, or say soil. So usually NTM, the human exposure is typically from the soil to the oral cavity and the respiratory tract. So that's the common way of this thing. The incubation can be can go up to right from day 1 till 5 years. That's an incubation period. So there are lot many NTM cases right now which we are seeing the rise in NTM cases. But I won't say there are rise in NTM cases. I would say rather the diagnostics have improved towards NTM, and that's the reason probably we are seeing more and more NTM cases right now. Trust me, histopathology will not differentiate you from NTM or MTB, So there would be only two tests. One is, suppose if you have done already a smear of a patient, which is showing a smear positivity, and same sample when you send for gene expert showing as negative. So you may suspect NTM for the case. That means AFB seen on smear, ZN stain positive, but the same sample subjected to gene expert showing a negative gene expert, yes, suspect NTM. Send the same sample for cultures, and the culture will be the gold standard technique for you to know whether it is MTB or NTM. That's the only way you can differentiate between both of them. But yes, usually the even the bronchoscopies, nowadays we are doing a lot of bronchoscopies. So if you don't clean your scope well, if you keep your scope in an unhygienic state, sometimes this scope, contaminated scope, can lead to a source of infection of NTM for other patients also.
Okay. So you have rightly said that NTM usually targets the children. There are environmental exposures are also one of the cause. Sometimes it can also be seen in immunocompromised host. And every smear is positive, gene expert can come negative, and you may get your diagnosis only on the cultures. Plus, there are specific LPAs are designed for the NTM also. So you can also, when your every smear is positive, gene expert is negative, and smear is more than 1+, then you can go for a specific LPAs which are targeted for NTM also. And treatment is as per the species of the NTM. So, Dr. Joydeep, will you let us know what are the dangerous signs of lymphadenopathy?
Yes.
What should be really worried about? In other words, what we say it's as a red flag signs.
Yes. So most of the time when we get into this lymphadenopathy, we thought the patient, we thought maybe it is a normal infection, so TB, but we should be very cautious of some red flag signs. Like if there is first the patient profile is there. If the patient is more than 40 years of age with loss of body weight of more than 10% in a few months, and if there is rapidly increasing node, single supraclavicular node, hard node which is clinically palpable, and associated any history of any malignancies in the past, and so this kind of thing can give rise to a red flag symptom. And sometimes if in FNAC we got inconsistent report, we should but the suggestive red flag symptoms are there, we should always have an excision biopsy and send it to appropriate investigation to see if any hematological malignancies like lymphoma or leukemia are present or not. So I think these are the main red flag point we should be cautious of.
Yes. So as you rightly mentioned that any lymph node which is larger in size, a smoker patient having a hard lymph node which is fixed to underlying tissues, any supraclavicular lymph node, and patient is having HIV with lymph nodes, or patient is having hepatosplenomegaly, or sometimes lymph node which is compressing the nearby vital structures like trachea or any other vessel or any nerves, and you should be very cautious and you should be doing the fast forward workup of that patient. So Dr. Ruby, you had given us a very elaborate explanation of how to approach a patient of lymphadenopathy. So just let us know in brief about how to investigate a lymphadenopathy. Just brief few investigations, just the headings.
If it's a cervical lymphadenopathy and it's accessible, or any other part of the body which is superficial and accessible, we could go ahead with the FNAC, and ancillary techniques like ultrasound, image-guided techniques, ultrasound-guided techniques, CT-guided techniques. These are CT-guided for intrathoracic or intra-abdominal lymph nodes. If it is there, they have increased the diagnostic yield of this FNAC. So FNAC is the procedure that we do, and that aspirate should be sent for AFB smear, for mycobacterial culture, and gene expert. So that is what we need to send for. Gene expert, that will give you the resistance pattern, and culture will obviously give you that. If it's a isolated intrathoracic lymphadenopathy, one could go ahead for bronchoscopic approach and do a TBNA, transbronchial needle aspiration, or an EBUS guided bronchoscopic. So EBUS guided aspiration also can be done if it's a isolated intrathoracic lymphadenopathy. If it's a intra-abdominal lymphadenopathy, which is isolated and you have just one node, then again a laparoscopic approach for an excisional lymph node biopsy, which is the gold standard. But we do not go ahead unless If you are getting the answer from an FNAC, if you are getting the culture report, then we go ahead and treat the patient. But if it's inconclusive, then we go ahead and do an excisional lymph node biopsy.
Okay.
Also, other techniques are true cut biopsy or core needle biopsies, which can be used, which will give you a better biopsy material. But better one is excisional node biopsy because it doesn't harm the architecture. So it is very important when we have to differentiate a lymphoma versus TB. So from malignancy point of view, excisional node biopsy is most important.
Okay. So you have correctly mentioned about the FNAC biopsy. Biopsy can be three types: incisional, excisional, or core biopsy. And you can do blind biopsy. You can go for the radiological guided biopsies. Okay.
Yeah.
So,
incisional biopsy, they can lead to sinus tract formation, and hence it is not preferred.
Okay.
So
now we have reached our investigations. We have reached up to cytology and biopsy. So I would now ask the multiple questions to Dr. Shilpi Dosi. Hello, ma'am. We are actually helpless without pathologist. A good pathologist can really change the face of a diagnosis. So, ma'am, will you just, I'll be asking you a few questions. So, how do you select a lymph node for FNAC? If I send you a patient who is having multiple lymph nodes, then how do you select it?
Yes. First of all, congratulate to all. You all have done my work very easy. When, as you all discussed, the cervical lymph nodes are most common extrapulmonary tuberculosis presentation, then mediastinal, and I think then axillary. So in cervical lymph nodes, when we have multiple lymph nodes, so first we have to give preference to the size, which is the most accessible and most largest lymph node. We prefer to do FNAC from that because that we yield more diagnostic material. And if then we palpate, if swelling is usually soft in the center and hard in the periphery, so we do FNAC first from the periphery area. From periphery area, there are more chances of cellularity. And if we do FNAC from central area, there are high chances of getting necrosis. And sometimes the rare presentation is cystic presentation also. So in this, we get first fluid, and then first we have to aspirate all the fluids, and then we do FNAC again. This is one more common technique. Then after that, there are two methods of FNAC. First is FNAC with aspiration, and one is FNAC without aspiration. So when the swelling is vascular, like in thyroid or in some lymph node also, we have to try FNAC without aspiration, without negative pressure, because in sometimes if swelling is very vascular, we because of this negative pressure, we get lot of blood in our needle. So this is a fruitless study. So first we have to try without aspiration. Then if material swelling is hard or something fibrous, then we try without negative.
Okay, ma'am. So you have just mentioned that one should target the most abnormal lymph node, which is the largest in size, and it should be most accessible.
And one more important thing is patient preparation is very important thing. Like a clear-cut explanation of the procedure to the patient, because when we do FNAC in our FNAC clinics, it is we don't use any anesthesia. So clear-cut explanation of what we are doing the procedure. It is a clear-cut. It helps in doing procedure, and we do some. We have to give some instruction to our patient when we do FNAC. If it is in central region, we have to extend the node, and for FNAC we have to first fix the lymph node properly, and we have to instruct the patient that you don't swallow this putum during this procedure and don't move. These instructions will quite help.
Okay, ma'am. So it is said that if there's a lymph node, then if it is a soft lymph node, then you aspirate the pus, it will give you a maximum microbiological yield. From the periphery, it will give you a maximum pathological yield. And the highest,
Yes.
Highest yield is from the supracaval lymph node, and the lowest yield is from the inguinal lymph node.
Yes, yes. Because inguinal are very vascular.
Yes. And ma'am, what is the sensitivity and specificity of lymph node sampling for tuberculosis diagnosis?
Yes, yes. Actually, there are three approaches to diagnose tuberculosis on this lymph node aspirate material. First, it's cytomorphology. So in cytomorphology, we get the 4 patterns. So first is that if it is only epithelioid granulomas, and if it is epithelioid granulomas with caseous necrosis. So epithelioid granulomas with caseous necrosis is quite helpful or quite diagnostic to diagnose that in India we said that it is tuberculosis. But if it is only epithelioid granulomas without necrosis, it may be sarcoidosis or some other fungal infections also. And when we get only necrosis, so there may be some necrotizing lymphadenopathy also, like Kikuchi disease or some Castleman also. And sometimes we get the necrosis with inflammatory material, like suppurative material in cold abscess. So it may be quite helpful. So we cannot clearly cut said that the cytomorphology is, we say granulomatous inflammation, but we don't conclusively said that this is clear-cut tuberculosis. For definitely we have to do some microbiological examination. We can do ZN staining and gene expert also. So like we can say the sensitivity of ZN stain in tuberculosis is 46% something, and specificity is 97%. So specificity is for ZN stain, specificity is high, but sensitivity is less. And one more technique is fluorescent staining, that is Rodham and Oramin staining. In there is opposite. There is a sensitivity is high, but specificity is low because there is lot of background staining also. But in gene expert, if we gene expert, the sensitivity is if we do only sensitivity is 55%, and specificity is quite good, 83%. But if we combine all these things, means ZN staining with gene expert, then diagnostic accuracy is quite high. Like it is sensitivity is more than 85 or 90, around 90%, and specificity is 85%. So if we combine all the procedures like morphology and gene expert and ZN staining, so diagnostic accuracy is quite high.
Okay, so roughly you can say that if you combine like this clear histopathology and microbiology, then the combined specificity and sensitivity is more than 80-85%.
Yes.
Very. Yeah. I would just like to ask Dr. Shilpi over here. You mentioned about Kikuchi. So where would you like to, keep this Kikuchi? How common is this Kikuchi? Because for us as a chest physician, many times we get a report from pathologists that it is just basically suggestive of, say, necrotizing lymphadenitis. And so what would be your takeaway for us that probably this would be a Kikuchi and not tuberculosis? And how common it is from your side?
So yes. In this 10 years of career, I have seen 3 cases of Kikuchi disease. But we have diagnosed it on cytology, Kikuchi. But on the histopathology, they are they are not confirmed actually, but there are more like reactive lymphadenopathy. And Kikuchi disease, when we see, there are lot of histiocytes are there, but no epithelioid like cells or no Langerhans type of giant cells, no proper epithelioid cell granulomas, but there is lot of necrosis, and sometimes these histiocytes also confused with us malignant cells also. So it is actually it is a diagnosis of exclusion.
Okay.
And there is no, I think, further molecular or genetic study to confirm Kikuchi. So it is a diagnosis of exclusion mostly.
Okay. So if you don't get any diagnosis and a lot of histiocytes, then you can think about Kikuchi disease.
Yes.
Okay. So one more question to you, Dr. Shilpi. Are there any recent advances or newer tests for lymph node approach from pathology point of view?
In recently, I have very fortunate that Dr. Ravi is my husband. So I have done many study rose techniques in the EBUS TBNA material. So how to guide our pulmonologists to maximize the use of this EBUS TBNA material to make the diagnosis whether it is malignant or tubercular. So we can, I think, like in lymphoma cases, even on EBUS TBNA material, we can do flow cytometry also. And if we make the cell block of this material, we can do IHC also on this material.
Okay. So,
but I think for tuberculosis, because most of the diagnosis made on sputum and bile fluid, bile is the best specimen in which we get the most of our microbiological investigations are positive. So bile is the, I think, best sample to diagnose tuberculosis.
Okay. And ma'am, just last question for you, ma'am. Do you advise any special precaution while handling the sample or sending the sample of lymph node?
Yes, sir. Yes, sir. It is a very important actually ki who is the performing the FNAC. Because in medical college, lot of these our PG residents doing FNAC, they are very, when we are in first year, they are very enthusiastic to do procedures. So they do FNAC themselves, and they do FNAC, but they all the material most of the time go wasted because they don't know how to make the smears, and then also they don't know how to trials this sample. So for FNAC, most of the time we use 2 to 3 passes for tuberculosis. One pass for this slide preparation. So we have to do we have to make the 2 types of slide, air fix and this wet fix. So wet fix is basically we have to take slide in the alcohol fixed media. Mostly we use 80 to 90% ethyl alcohol or this time, and air fixed are for our Romanovsky stains. So smear preparation should be good. We make this by press method. Once take material on one slide and then just press it. And because we have to, our motive is to make slide to see these monolayered sheets of cells. Because there are, when our clinical side people make slides, there are a lot of overlapping of slides. They take all the material on the one slide. So there is quite a crowd slide and a lot of inflammatory cells, and they all one slide. So we have to make many slides, and now it is a new concept. We don't waste all material to making slides. It is just exhaustion of our material. So if we see on the rows that our slide showing all morphological material quite right, so we take all the material into our normal saline and send to our pathology. They will do separate this material, microbiology for normal saline, and for histopathology make this cell block and formalin, and they further tries this material for further testings.
Okay, well. So you have given a very clear message to all the residents or all the pulmonologists. If you are making a slide, just make a very thin slide, single layer slide. Slide can be fixed into a alcohol as well as air fix. Plus, you can send the sample for microbiology only in normal saline.
Normal saline.
Send a sample for microbiology in formalin. If you are targeting a histopath, then please send the sample in formalin.
Yes.
So, ma'am, you have really given a very broad and very specific perspective to a pulmonologist from pathology point of view. Thank you, ma'am. Thank you very much, ma'am.
Thank you, sir.
I'll keep troubling you in between.
Yes.
Whenever the questions. So, next I'll ask Dr. Vikas How should we approach a persistent lymph node which is there for almost 6 months of ATT? And in your practice, what are the causes which you find in a persistent lymphadenopathy?
Yeah. So I would just like to answer this question. I would like to just share one case over here for the same. Is my screen visible? Okay. So this was a 25 years old female who was having a swelling of the neck since 2 months. There was a weight loss, no cough, no fever, no past history of tuberculosis or any TB contact. This is what she has come with on day 1 with the presentation of good cases like material already discharging, oozing over there, a big lymph node. And this node was there since 2 months. She used to apply some desi Ayurvedic jadi booty and all. And this is what you can see. Right? Very obvious, like Sufrisha type thing, like very much obvious that is tuberculosis. Just went ahead with the biopsy the case. Histopath suggestive of caseous necrosis, probably tuberculosis. Yes, it was confirmed tuberculosis. Expert was been sent, as we already do. Whenever we take a biopsy, we just divide the sample in 3: 1 in formalin for histopath examination, and 2 in normal saline for gene expert and LPA and MGIT culture. This is our protocol. And gene expert had already shown over here as RIP sensitive. We just started her on first line drugs. Meanwhile, we also got LPA report, which also showed that yes, both H and R are sensitive for this case. So yes, a clear-cut sensitive case, no past history of tuberculosis, no contacts of DRTB, patient was started on first-line drugs. But hardly we could see any response, even after 6 months of completion of treatment. Since this node was quite a big, so after 2 months, it was very much too early for us to conclude on some judgment that probably this would be a irresponsive or not responding treatment. So we waited for 6 months. And post 6 months of treatment, when we saw this node just suppressed, but not completely gone. But yes, it was still there. So this was the case after 6 months completion of treatment. It had regressed to size, but still it was persistent over there. So probably now we thought, that H and R were sensitive. So let us now just pounce on some more DST also again, repeat our diagnosis over here. We decided to put in a needle again over here after 6 months of treatment. And surprisingly, we found that yes, it was risk sensitive, but culture came positive over here again. So which we were not expecting our cultures to come positive. So if the cultures are positive 6 months of treatment, that means yes, still this is a failure on the treatment and probably is not responding on treatment. But yes, we were again surprised to see one more thing. Though the culture was positive, the DST showed as pan-sensitive over here. So approach, if there is a lymph node, if it is not reducing in size, probably it would be a MDR TB. So you need to reconfirm your diagnosis. You need to put in a needle again. And again, if it is pan-sensitive, probably now our next call was to do a TDM. Probably the drugs were going inside, but they were not getting absorbed in our body, blood levels. So we decided to do a TDM for this case. Yes, here we were right. Rifampicin levels were just less than 0.2 milligram per liters. We were lucky enough to have Hinduja over here at Mumbai, where 8 to 24 was the normal range. This is nothing but, you just consume blood at your normal time, and within exact 2 hours of your consumption of the tablets, the sample has been withdrawn and the levels of the rifampicin and isoniazid is been checked. And this is what we got the report. Both rifampicin and isoniazid levels were on the lower side. And after this report, we just decided to increase the dose of rifampicin, and we gave her 450 plus 600 milligrams rifampicin, where her requirement was only of 450 milligrams, but another adding dose of 600 milligrams were given. She was been restarted on around 450 plus 600 milligrams rifampicin with 3-time dose of isoniazid, that is 900 milligrams of isoniazid, with pyrazinamide ethambutol again restarted. And this was a response which we got after again 6 months of treatment down the line. The node size were absolutely gone. You can all see this is absolutely cured. Yes, we were lucky enough to have Hinduja near to us. So a message over here to this case, there are 3 messages. One, suppose if the lymph node size was small in the day 1, patient started on AKT after reconfirming the diagnosis, that is, if the gene expert was sensitive, the lymph node size, that then reducing, if it has increased in size, it could be either DRTB or it could be iris syndrome over here. So iris, you can suspect only if the lymph node was smaller on the day 1, but increased after 2 months or 3 months of treatment. That is, there is a paradoxical reaction. Instead of reducing the size, there was an increase in size. You may think of paradoxical reaction. Repeat a biopsy over there. Let the gene expert be repeated. If it is again gene expert sensitive and culture sensitive over here, and the lymph node size was increased, it is nothing but iris syndrome over there. You need to give steroids to your patient. With the coverage of AKT and steroids, the size will reduce down the line. But if the size was like, say, 3 centimeters, down the line has reduced, but not completely gone. And again, you think of maybe DRTB or maybe polyter resistance, HNR sensitive on day 1. Maybe your pyrazinamide not working, ethambutol not working. You need to reconfirm your diagnosis over there. Down the line 2 months, repeat a biopsy, get a fresh DST done. If it is pan sensitive again, then you may think of low drug levels in your blood. You may need a requirement of therapeutic drug monitoring. Unfortunately, program don't support TDM. Under the NTEP, we don't have TDM. There are very few labs who do TDM. But yes, if you do have, say, resources nearby to you, please do take help of this tool. It will definitely help your patients, where we have at least 74 such cases where we have given increased drugs or increased dosages of rifampicin and isoniazid, and we have found a fantastic result. But to be very cautious over here, if you're thinking of iris syndrome, that is paradoxical reaction, and you're thinking to give steroids to your patient, you should be very much confirmatory that yes, your drugs are working, they are still sensitive, and sensitive drugs and steroids along with the sensitive group of drugs, you can take get rid of the iris syndrome over there.
So that was a very nice case which you have described to our audience. Thank you, Dr. Vikas, for that. And I'll just summarize that if there's a persistent lymph node, then you must rule out drug resistance. If to begin with, it was drug sensitive. If still on the repeat, it comes to pan sensitive, then you should again look for the drug absorption as well as by doing the TDM, that is therapeutic drug monitoring. Even if the next thing would be a paradoxical reaction, that is iris. And the fourth one would come in picture of persistent lymph node is any coexistent two diseases. Like sometimes tuberculosis malignancy can also even coexist.
Your diabetes should be under control. That is very important. If the patient is diabetic, sugar levels should be under control. If sugar levels are not under control, at whatever drugs you give in a right format, probably you won't get rid of this disease.
Yes. So fifth one is to control the diabetes.
Very important.
Very.
Dr. Mahesh, I have a query here. Just wanted to ask Dr. Vikas. In that case, the last case, I mean, would it be a good idea to go for an excision biopsy of that, since it's a very isolated lymph node?
Yeah.
Would it help if we go ahead and do an excision biopsy?
What happens, sir? Many times what happens is excision biopsy. Many times we have just given AKT with medical management. The lymph nodes have they do regress completely without even excising them. That is what we do, because down the line, suppose as a physician, if we need some more say information down the line, say 2 months or 6 months down the line, and if we excise the complete lymph node on day 1 itself, we don't get the further tissue samples for diagnosing them further down the line if required. So usually, if you see in our cases over here, we don't think of excision biopsy, excising it completely. We just go on medical management. And with the right drug of AKT, right dosages of AKT, the lymph node has been taken care within a period of 9 months to 12 months. It completely just go away.
Right. Thank you so much.
Add to Dr. Vikas, I would mention that if there is a lymph node where you haven't ruled out drug resistance, or that is not a completely treated lymph node tuberculosis, then once you excise the lymph node, chances of forming sinus and fistulas are very high.
Very high. We have seen 2-3 cases where there was an open sinus tract completely oozing even after down the line, say around good 9 months, 12 months of management. And sometimes we do require steroids to be given to such patients. where we need to be very cautious whether our drugs are still working, whether we are giving steroids with the right coverage of AKT, working drugs of AKT or no. So those are a dilemma for all of us as a physicians. So we prefer to go ahead with just biopsies than excision biopsy.
Right.
And also, this is an age-old practice that is taught for while handling a lymph nodes of tuberculosis origin, that even if you go for the FNAC, go for the non-dependent aspiration.
Yeah.
Otherwise, there are chances that it may form sinus of fistulas in future. So, now we are discussing something related to paradoxical reaction. So, I'll ask Dr. Ruby, how many patients do you see in your practice can have a paradoxical reaction while treating a lymph node tuberculosis?
That comes to around 20%. It's various papers say a varied range from say 5 to 23%. So you can take it as 20% in patients who are HIV uninfected, and this percentage is higher in patients who have an HIV with TB. So paradoxical reaction is when they drastically improve, and then once the immune reconstitution happens, they paradoxically worsen while on ATT. So this can be seen in both HIV affected individuals and HIV uninfected individuals also. So it could be a paradox, and there are two types basically: paradoxical reaction and unmasking reaction, where subclinical TB gets unveiled once you start treatment with ART, that these signs and symptoms of TB are not visible initially, but once you start the ART, they show signs of TB, and that could be called as unmasking. So around 20% of individuals show this TB iris.
Okay. So as you mentioned that it ranges from 5 to 23%, but 20% is roughly we can take. Plus, it's seen mostly within the first 3 months when the immunity is building up after treating the patients with ATT, and this is related to an antigen exposure. So that's why it's known as a paradoxical reaction. So then I'll ask Dr. Joydeep how to treat such paradoxical reactions.
Okay, so we know that paradoxical reaction identification is very important, because before treatment we should try to prevent this paradoxical reaction. How could we do that? By screening of both HIV patient for TB and for TB patient for HIV, because if you identify both these diseases at the same condition, there can be a delay in starting ART. So in TB patient going to HIV, we can first start the ATD, and then after more than 2 weeks, we can delay the ART so that this kind of reaction doesn't happen. And if there is a presence of this paradoxical reaction, then we have to identify, is it a paradoxical reaction, or is it due to some secondary bacterial infection, or due to some treatment failure due to drug resistance. So if there is a secondary bacterial infection, we should treat those by proper antibiotics. Most of these paradoxical reactions can be treated by symptomatic treatments only, because they are actually due to delayed immune response, and they can be self-limiting. Whenever there is an insurgence of inflammation and more reactions can occur, if there is a more fluctuation, more abscess formation, we can easily drain those to relieve the symptoms. And sometimes there are some studies they can use steroid, but there needs conclusive evidence. There is no proper guideline about in which cases steroid should be used and in which cases are not. So that is how we can treat those reactions.
Okay, so you have rightly said that while coming to a conclusion of paradoxical reaction, you must rule out first drug resistance, and second, as Dr. Vikas mentioned about, always go and check for the even drug levels also. Once you rule out this everything, you come to a conclusion of paradoxical reaction. So we can see that it's an diagnosis of exclusion, and treatment is mostly self-limiting. Sometimes these patients can also be treated with normal NSAIDs. And in severe cases, only you may require steroids.
Yeah, so this paradoxical reaction doesn't, mean that there is only lymph node increase in size of lymph node. Sometimes the paradoxical reaction may present in the form of, say, pleural effusion, or sometimes in the form of, say, ascites also. Yes. So there would be a reactionary fluid anywhere in the body sometimes. Sometimes there is just increase in size of lymph node. But you just need to be very cautious when you use steroid. Your patient should be sensitive to the drugs, given drugs. And yes, steroid will definitely help you to a great way. We have gone even up to more than 1.5 milligrams per kilogram also. 0.9 to 1.5 this thing per milligram per kilogram for our cases.
Okay. Thank you, Vikas, for your wonderful insight. So the next, I'll ask the next question to you only. You have managed more than 9,300 drug-resistant tuberculosis patients till date, and you look to be a very young person. People usually don't see this much of patients in their lifetime, which you have treated till now. That's really a wonderful credit to your work profile. So I would like to ask, how much do you see this lymph node drug-resistant tuberculosis patients, and how do you approach it?
So nowadays, initially, I still remember in my initial days of practice, just to say 10 years back, the lymph node TB probably would have been some 20 TB patients compared to 100 TB patients seen in a day. And nowadays, I'm seeing at least 35 to 40 TB patients compared to around when see 100 TB patients in a day. Say if you see coexistence, around 40% of the patients have got coexistence of EPTB and PTB for both the diseases now, for DRTB now. So the approach would be, if the patient, my approach is basically not my approach, rather I would just request for each and everyone over here. I don't know, somehow I don't believe in FNACs over here because we get very minimal sample in FNACs. We do require a good chunk in a biopsy where you can send all together, as Dr. Shilpi has also mentioned over here. You need to, your yield increases when all the samples goes together. You need to send your histopathology, you need to send your gene expert, you need to send your LPA, you need to send your MJIT culture for the DST. So you need to send all this at one go itself than picking the patient 2 times, first for FNAC, confirming for reactive lymphadenitis or chronic non-specific lymphadenitis or TB lymphadenitis, and then doing your biopsies. It doesn't give any sense. Rather go ahead with the biopsy, have a good sample, divide it by 2, 1 in formalin for histopath, 1 for normal saline for all other tests like gene expert, culture, LPA. Prove it that it is sensitive TB. If it is sensitive, give an appropriate drug dosages for no divided dosages at all. Give all the drugs together at one period of time. Do not divide the dose morning, afternoon, and evening. See to it that adherence is good. Follow up after 2 months. 2 months is a very appropriate period to check and to judge whether the drugs are working or not working. Baseline compared to baseline, the lymph node size should decrease within a 2 months period. It should decrease. If it still remains persisting or if it is increasing, think for either non-responsive treatment or maybe non-adherence, bad compliance, poor compliance, or maybe if it is increasing, think for iris syndrome or DRTB. So if it is same stagnant within 2 months of taking a proper drug AKT, good compliance, then probably a non-responsive treatment over here. Probably you may think of doing TDM for the patient. The drugs are not getting absorbed. But if the size is increasing, think of iris syndrome, think of DRTB. Repeat a biopsy at the end of second month. Please do not, hesitate to put in a needle again. Counsel your patient. The lymph node size was 2 centimeter. Even taken treatment properly, still it is 2 centimeter, or now it has become 3 centimeter. It is a worrisome factor. We need to reconfirm the diagnosis over here. हमको आपका diagnosis confirm करना ही पड़ेगा. Put in a needle over there. Reconfirm. Send the gene expert. Send LPA. Send culture again. That's the reason. Don't think of the expenses. Get collaborated with the NTEP. There you can send free samples and you will get a good diagnosis free of cost. If you don't have an approach of NTEP, no problem. Counsel the patient at least for gene expert and cultures. Very important. A gene expert will give you a good yield. Also 80 to 85% for a lymph node TB. It will give you a good diagnosis. Do not worry. At the end of 2 months, reconfirm diagnosis. If it is with resistance, please do not hesitate to switch over from sensitive drugs to a DRTB. But if it is still a gene expert sensitive at the end of 2 months, also LPA, very important. Reconfirm INH status, whether INH is working or not working. Because we have 12 to 18% of mono H resistance over here. Even if your INH is resistant, which was not been picked up on day 1, your regimen is going to fail. You may require second line agents over here, or you may require to add on second line drugs if you have INH resistance over here. And then probably if at the end of 2 months also, if it is DRTB, you need to switch over the entire regimen from a sensitive to a DRTB, depending upon the LPA or the culture report. So the point over here is Even if you feel a need of putting a needle at the end of 2 months or even end of 6 months, go ahead, repeat the diagnosis. Do not give just clinical judge-based treatment. We do have all the tools available in the market. Please make utilization of all the tools. Have a good microbiological diagnosis than a clinical-based practice.
Dr. Vikas, will you please throw some light on drug-resistant tuberculosis lymph node management?
Yes. So day one, RIF resistance. Now the management will be same for PTB or EPTB. We can give BDQ-based regimens for EPTB also, no problem at all. BDQ, Leoflox, cycloserine, clofazimine, the same drugs can be given with linezolid, no problem at all. Just have a baseline investigation done as a pre-treatment evaluation. ECG would be required to see for the QTC prolongations, normal QTC baseline. We need some opthal evaluation for linezolid. We need some basic biochemistry tests, say certain blood tests, blood investigations to check for our platelet counts and the hemoglobin, and go ahead with second line management, no problem at all. Same approach would be at the end of 6 months, go again for an ultrasound, check for the lymph node size. If the lymph node size is reducing, your management is good enough, your patient is responding. But at the end of 6 months also, if the lymph node size have increased, you may think iris in DRTB also. So iris is not only in DSTB, it can also be present in DRTB, where you will require a coverage of steroids with an appropriate working drug. The steroid will take care of the iris syndrome, the paradoxical reaction will come down, and the patient will be relieved definitely. Patient may need treatment for around good 18 months. Sometimes it may also require an extension of 2 more months or 3 months more, maybe around 20 months. So that would be depending upon the end investigation again, compared to the baseline. At the end, if the lymph node size becomes less than 10 millimeters, that is a sub-centimeter size lymph node with some calcification in it, do not worry, you may stop the treatment, it's okay. But do not forget to repeat the ultrasound after 6 months of stopping the treatment and the follow-up after stopping the treatment to reconfirm the reactivation or the relapse, if any.
Okay. So the drug-resistant tuberculosis management remains same as a PTB. There is no change. Okay. And very well, you have picked up, you have mentioned about one thing, that paradoxical reactions can even occur in DRTB also, where you may require steroids. That's a take-home message for us. Thank you. Thank you, Dr. Vikas, for wonderful elaboration of drug-resistant TB management. So just little while back, Dr. Abhijit had asked about the lymph node excisions. So Dr. Ruby, when do you suggest the lymph node excision?
Usually, like Dr. Vikas said, it is not the treatment of choice. We would prefer to give a medical management so that the nodes can regress. But in case it's a very large fluctuant node, particularly in the cervical area causing compression of the vital structures or discomfort, then surgical excision could be, as per a paper, it was suggested that it could be advised also for paradoxical upgrading reactions which are not responding. It could reduce the duration of the iris when surgical excision is done. Also, in recurrence of the EPTB, the lymph nodal TB, which is recurring or resistant to treatment, and it is large. It was shown in a paper, but I'm not sure whether it's a guideline per se. We don't have access, guidelines to say that, okay, go ahead and go for an surgical excision. But in those which are having fistulas, the draining sinus, which is not at all responding to whatever treatment we are giving, surgical approach would help to elevate the patient's symptoms.
Okay, so you have rightly said that whenever there's a FNS is inconclusive, you can go for a drug excision, but that is not the first thing which we advise. So first is the FNS is inconclusive, even non-responding paradoxical reactions, plus sometimes cosmetically also patient can ask for lymph node excision. Even whenever we suspect that there can be a risk of coexistent malignancy, you can ask for lymph node excisions. And in cases of NTM, non-tuberculosis mycobacteria, it is a diagnostic as well as it's therapeutic.
I would also like to add, because coexistent pulmonary TB can occur with EPTB, so a sputum examination, which I missed out earlier, so that is necessary for all patients who come to us with a lymph node TB. Sputum examination for AFD and vein expert should be sent for all patients.
So usually, sometimes this is an stigma that somebody suffers a tuberculosis, then that patient is usually isolated. So usually in case of lymph node tuberculosis patient, we advise for the sputum. And if sputum is negative, then we can roughly say that this patient is not infectious. So you have raised a very right point. So Dr. Vikas, I'll ask you again one more question, and this is just little different questions from the tuberculosis. Are there any drugs that which can cause lymphadenopathy?
Yeah, I think it was mentioned by Dr. Joydeep also and Dr. Shilpi also, that some of the drugs, like say allopurinol, some of the even the drugs like carbamazepine, cephalosporins, and these are very commonest drugs which are being used by us. They also do lead to lymphadenitis. So you just need to, he had mentioned about taking a good history. In history, it is very important to ask which drugs you are on, because that would be an approach. Probably, yes, these are the drugs like quinidine or say sulfonamide or spiritoin, probably very commonest drug used by neurologists for seizures. These are the commonest drugs which may cause lymphadenitis also. So history will rule out these things if these patients are on these drugs and lymph nodes. So don't just directly jump for FNAC. You may just think of drugs and then you can just avoid invasive procedures. Probably.
After the paradoxical reaction, as a diagnosis of exclusion, we can even consider drugs also, other drugs. Yeah. So again, that history taking is a gold standard for approaching any case. So Dr. Ruby, I'll ask you one more question, that what are the complications and sequelae of specifically a lymph node tuberculosis you see?
Yeah, so with the right treatment at the right time, almost 30 to 40 patients of lymph node TB, they regress within 3 months of treatment, and 80% regress within the complete 6 months treatment. But few of them go towards complications, and this would be based on their location. So if it's a cervical TB, mostly they go in for erosions, sinus tract formation, abscess formation, cold abscess, collar-sted abscess formation, and draining fistulas. So if it's a mediastinal lymph node, they could go for compression of the trachea, causing bronchial stenosis, tracheal stenosis. It could compress the recurrent laryngeal nerve, leading to vocal cord paralysis and hoarseness of voice. Dysphagia is another symptom which could happen. Subcarinal node, if it causes compression of, again, the esophagus. And it could also lead to esophageal perforation. There have been instances where tracheoesophageal fistulas have been reported. If it's an abdominal node, especially if it's hepatic node, they could cause compression and cause jaundice of the hepatic area. And renal artery occlusion can cause renovascular hypertension. So these are the few, depending upon the location, they could cause compressive symptoms. They could go ahead and have ulcerations, erosions, and sinus tract formations.
Okay. So you have just elaborately mentioned about how to manage the complications sequelae of lymph node tuberculosis. So now you have mentioned about the sinuses and fistula as a complication sequelae. So Dr. Vikas, apart from the surgery which we advise after ruling out secondary infection or after ruling out drug-resistant tuberculosis, is there any role of local application of ATT drugs? Because there are anecdotal reports which mention that you can crush the ATT drugs or ATT tablets and put on the local regions. This may help in healing the fistula sinuses. Is there anything?
Definitely, it won't help. There are no studies yet which have proven that local applications will help, clearing the sinuses. But yes, we have got some studies where aminoglycoside, use of streptomycin powders or say kanamycin or amikacin powders, when they are applied, especially on the Montux, the ulcerated Montux, this thing which they have got, or sometimes even on the open sinus, they claim that they have got good response, but I don't think that this would be helpful. You need to have a good blood absorptions of the drugs. That too, all the drugs given together can only take care of these intracellular killing bacteria. We need to target all these bacteria or drugs together. Local application definitely won't help.
Okay. So we can say that while approaching the sinus and fistula, rule out drug resistance, control the secondary bacterial infection at a local site, and we can say that by applying this rifampicin and aminoglipron at local site, it may give you an antibacterial effect rather than an antimicrobial effect. Okay, but there are no proven studies for the same. Okay. So this is, I think, now we have almost covered almost every aspect of the lymph node tuberculosis. So now we'll go for just few audience questions. There are, I think, more than 70 or 80 questions. We won't be able to answer each and every question. So we'll take some of the questions. So this is a question by Dr. Yash Kathuria. He's from Uttarakhand, Haldwani. He has asked asymptomatic mediastinal lymphadenopathy, how to approach it? Asymptomatic mediastinal lymphadenopathy.
I would like to take this question over here. Suppose mediastinal lymph node is also very much common right now, usually picked up on X-ray chest primarily. Patient may be asymptomatic, but have got an X-ray chest done due to some other reasons, maybe whatever reason. Sometimes even the screening of the, screening for the visa purposes and all. Many of the patients did to come us, sir, visa ke liye gaye the, X-ray nikala hai, usme kuch ek daag dikha raha hai, kya karna hai? So such cases, they are basically asymptomatic, probably, maybe in a dormant phase. Sometimes you never know. You need to get a CT scan done for such cases if it is a good prominent opacity over there and you're suspecting a mediastinal lymph node. Get a CT scan done with a contrast, and if it is a necrotic lymph node, sometimes you won't find a surprise over there to say, see a good necrotic lymph node sitting over there, and probably it was lying down over there since many longer duration of time. You need to put in a needle over there and get it diagnosed. It is very important, especially in a country like India, and that too if you are somewhere in Mumbai, around in Mumbai, and if you find some lymph node, you need to put in needles. It's very important, because right now Mumbai, I don't know about other regions, but yes, Mumbai right now we have got exposed to, every second person walking down the line is having tuberculosis. This is what we are finding over here. So exposure is really high. Lymph node cannot be left undiagnosed. You need to diagnose it if you find a lymph node, mediastinal lymph node over there.
So, as you have correctly mentioned, that mediastinal lymphadenopathy. Now we have Dr. Shilpi had mentioned when I was talking to her that to approach a mediastinal lymph node, you may require either a blind TBNA or EBUS, yes, and process the sample for even histopathology, cytology, and cultures. Plus, if you have an mediastinal lymph node, you take a detailed clinical history and even just think about the sarcoidosis as well.
Sure.
So there is one question by Dr. Karthikeyan from Tamil Nadu, Coimbatore. What is the best way to isolate TB bacilli from a lymph node or a cold abscess? If lymph node biopsy is suggestive of casus necrosis with Langerhans giant cells, is it sufficient to take it as tuberculosis even if FB stain is negative?
I think it is confirmed by gene expert.
Okay.
Yeah, it depends upon the bacilli, number of bacilli. You require minimum 10,000 bacilli bacteria for it to come positive on ZN smear, whereas it requires hardly less than 130 bacilli to commit positive on gene expert. The sensitivity is very high, and nowadays, since we have ultra with us, more fortunate, for us, hardly just less than 21 bacilli also will give you a positive gene expert, a very good yield, rather, very good sensitive tool. So you don't require a ZN smear always to be positive nowadays. You just send a sample for a gene expert, LPA, and cultures together. That's the reason she mentioned send all together. Jaruri.
So even if there's a casus necrosis, there are the other causes of casus necrosis also apart from tuberculosis.
Yes.
Yes.
So as Dr. Shilpi mentioned, they will label it as a granulomatous
necrotizing lymphadenitis also.
So, one more question by Dr. Mahendra Singh Raghuvanshi from Madhya Pradesh. If there is a cold abscess, then what we should do, either needle aspiration or incision and drainage. Dr. Ruby, Dr. Vikas, Dr. Joydeep, Dr. Abhijit.
If there is a cold abscess, a very soft part, you don't require to incise and drain. If it is, not a good, large, big, inflamed part over there, probably only putting a small needle and just aspirate the pus out. Many times you can aspirate even good 15, 20 ml, 20 cc of fluid by a good syringe. That's more than sufficient. You don't require to give an excision over there, because incision will give you a sign, give you a good mark. Healing would be, the requirement of healing would be very much the same. Than a small needle, just a 10 cc syringe needle, and just aspirate. Your all abscess will be out and send it for further investigation. More than enough.
Actually, I would like to take that in cases where in the past where we used to get chronic retropharyngeal abscesses and cold abscesses. So the previous approach we used to have was doing an IND and drain that abscess. But now, as you said, we have changed our approach, and currently our first line is to do aspiration, and we get sufficient material. If you use slightly large bore needle, you will get adequate amount of material for our tests. So aspiration would be the choice, I think.
As you have mentioned correctly that it is a cold abscess. So either you drain the abscess or the abscess will find its way. Either it will go internally or it will come out to form sinus or fistula. So if there is an abscess, you have to drain it. Does not mean that you should go for an incisional and drainage. You can even go for the non-dependent aspiration. So one more question by Dr. Pravat Kumar Sahu from Odisha, Bhubaneswar is asking, can lymph node be affected without involvement of lungs?
Yes.
Many times you won't get pulmonary TB at all. It may be just an extrapulmonary lymph node. So yes, it can be. I think there is one question for me by Dr. Sudarshan Puthal, asking for how did you decide the dose or ideal dose of rifampicin and INH for the case of low drug levels? I would just like to answer him that if the rifampicin level were too low, we just took the percentage of it and then gone for the higher dosages. And second way is when you decide a higher dosages, you can reconfirm it by giving a higher dosages of rifampicin to the patient and reconfirm the TDM blood levels of the higher dosages of the patient. You can do that also.
There is a question from Dr. Saginder Samaraj from Tamil Nadu, Villupuram. He's asking the ATT duration in lymph node TB. So ATT duration in lymph node TB is 6 months. As lymph node tuberculosis is a paucibacillary disease, even the multibacillary disease can be treated with the 6 months of ATT. Why can't there be a 6-month ATT for the lymph node tuberculosis?
So minimum it is 6 months. Not necessarily for all the patient. Let me be very clear. You cannot stop all the cases within 6 months of period, which has been done on the field right now, which we are seeing, unfortunately. You need to reconfirm it at the end of the 6 months. You need to do an ultrasound to check for the activity, to check for the presence of the lymph node size. Probably if there is still an active caseous material over there and it is still 1.7 centimeter size lymph node, you cannot stop the treatment. Baseline was 3 centimeter, now it is 1.7 centimeter. Go further down, treat him adequately for more another 3 months, repeat an ultrasound over there. And now if there is a calcification of lymph node with a subclinical sub-centimeter size lymph node, would be an appropriate ideal way to stop the treatment. But do not fail to repeat an ultrasound after 6 months of stopping of the treatment. That is very important. Similar one question is related over here and asked by Dr. C. Mohan Rao from Odisha, Bhubaneswar, that what would be the management if you find a new lymph node of a treated case? So I would just like to answer him. Suppose if you have already treated a case adequately and stopped the treatment, and in the similar way, after down the line, say 6 months, you find a new lymph node, you have to re-evaluate is the only answer. You have to put in a needle again. You have to do a repeat biopsy. You have to send all the investigations again and retreat the case again. It is very important. But one thing is very important over here. 6 months period and only gene expert showing positivity and MTB as low, don't consider it as positive. It may be even a dead bacilli coming positive on a gene expert. You need to wait for the cultures to come positive. So do not overtreat your patient within a period of just 6 months or a year. If it is a same site, just a small increase in size, it's okay. Just wait and watch. Give him some just antibiotics, anti-inflammatory, and wait and watch. But if there is a new lymph node at a different site and say a different lymph node which was never there before, and if it is again a gene expert positive, then yes, please do retreat him. That is very important.
So there is one more question by Dr. N. Prasanna Kumar, Kerala, North Parvur, Ernakulam. Is tuberculous lymph node a notifiable disease?
Each and every TB disease is notifiable. You need to notify any kind of TB, let it be pulmonary or extrapulmonary. You need to notify.
The one question by Dr. Rashid from UP, Varanasi. Can we add levofloxacin and streptomycin with HRZD in lymph node TB?
Never do that if your patient is gene expert sensitive on baseline. Do not add any second line drugs to your first line drugs. In the world of TB drugs, first line drugs are the best drugs, the most potent drugs. It's our myth that by adding any second line agent, we are going to strengthen a regimen. No, the second line drugs are still not that potent compared to the first line drugs. Our first line drugs have very good bactericidal and bacteriostatic activity and sterilizing agent. They are more than sufficient HRZE for an adequate period of time, but in an appropriate dose and given all together. Most important.
So there are many questions which are pending, but because of the lack of the time now, we should come to a conclusion. So I'll just summarize whatever we have discussed today. Then I'll take a concluding remark from all the panelists. So when we started, I mentioned that lymph node is the most common form of EPTB in India, which accounts for around 35% of extrapulmonary cases. It has equal sex predilection. However, in worldwide, more seen in female patients, but in Indian setup, it's more in male. There are different risk factors, as mentioned by Dr. Ruby, like old age group, malnourished, smokers, alcoholics, and diabetics. The typical patient is a non-smoker, young person, commonly male, who comes with a swelling in cervical region, and it may have a little non-specific symptoms of TB lymph node swelling. However, there can be a symptom due to a compression of lymph node on surrounding structures like trachea or vessel or any other nerves. The normal lymph node size is a sub-centimeter except the epitrochlear. And even the lymph node up to 1.5 centimeter of upper jugular digastric and 1.5 to 2 centimeter of inguinal lymph nodes are normal size lymph node. The differential of lymphadenopathy are exhaustive, as mentioned by Dr. Joydeep. And in children, the most common cause of lymphadenopathy is infection, mostly viral. And in immunocompromised or in children, NTM can be one of the reasons of lymphadenopathy. Old age with smoking history with the heart lymph node, you must rule out malignancy, and one should have a very aggressive approach if the red flag signs are present, like persistent lymph node more than 2 centimeter, which is hard on palpation, if it is in supraclavicular region, or it is associated with systemic symptoms, or it is and generalized lymphadenopathy, that is more than 3 non-contiguous lymph nodes are involved, or there is a concomitant hepatosplenomegaly. Generalized lymphadenopathy requires an extensive investigational approach. The specific investigation targets the FNAC and biopsy. The FNAC should be done non-dependent, can be blind as well as radiology guided. Biopsy is not a first choice, but however, when there are big lymph nodes in children which are more than 2 to 3 centimeter, to rule out the lymphoma, you may require an excisional biopsy. The types of biopsies which vary from core biopsy to incisional biopsy to excisional biopsy. If an FNAC is inconclusive, then you can go ahead with an excisional biopsy. The persistent generalized lymphadenopathy is there is a lymph node which is more than 1 centimeter, which is more than 2 non-contiguous sites and which persists for more than 3 months. This requires an exhaustive investigational workup. Then we had some discussion regarding the lymph node tuberculosis treatment, which is for the 6 months. However, some of the patients may require the extension of the treatment. Even the WHO guideline, which mentioned that the 4 month of treatment regimen can be used, which incorporates the 2 months of HRZD and 2 months of HR if it is a non-severe forms of lymph node that is without suspicion of or evidence of DRTB. But this is not applicable in Indian setup. Plus, paradoxical reaction is a diagnosis of exclusion. It usually appears in the first 3 months. It is an immunological response, more seen in HIV patients, and the treatment ranges from observation to anti-inflammatory, from NSAIDs to systemic steroids. And if it is still persistent, then you may sometimes require an excisional biopsy. The complications and sequelae ranges from sinus, fistula, to erosion into and surrounding vital structures. So this is what the gist of the whole discussion which we have today. So I'll request all the panelists to give an concluding remark of today's discussion to our audience. So I'll begin with Dr. Vikas.
Yeah, lymph node tuberculosis. I will talk only about tuberculosis. Ultrasound, I would prefer FNAC, go with biopsies, formalin, normal saline, formalin for osteopath, normal saline for gene expert, cultures LPA altogether. Treat appropriately. If it is sensitive, do not add second line drugs. If it is resistant on day 1, add second line drugs. Down the line, 2 months or 6 months, need to repeat an investigation, check for the decreasing resolutions of the lymph node. If it is still the same, think for irresponsive treatment or the poor compliance. If it is increasing, think for iris or DRTB. If it is reducing, fantastic. You can think of stopping of treatment. If it is less than 10 millimeters of size and calcified, sub-centimeter size lymph node and calcified, you can think of stopping the drugs and repeat an ultrasound after 6 months of stopping the drugs. Just of everything. Thank you.
So Dr. Ruby, Dr. Abhijit, Dr. Ganguly, Dr. Shilpi Dosi, would you like to give some concluding remark to our audience?
Yes. I will tell that FNAC, however, it is a very cost-effective and less invasive technique, but how to do a lot with a little. It is my dictum. So proper triage of sample for cytomorphology, histopathology, and microbiology. We should make some standard operating procedure during these FNAC procedure to guide our residents to guide how to take the sample and how to process the sample and how to send the sample to the pathology. We should make and we should teach our students also. Okay. Thank you.
I would like to ask a question, Dr. Mahesh. Dr. Vikas, in your vast experience, how many patients have you referred for surgery or surgical removal for treatment purpose? Because
trust me for this, won't lie, but till now, hardly 1 or 2, that's it.
Okay, so it is not advisable to send unless it is life-threatening, is it?
Unless required, yes. Because one I still remember was a good hard lymph node and was compressing the carotid over there, was very much inflamed, which was not even very much caseous. It was very much hard. That was the lymph node size. I still remember I need to excise it and just get rid of it. And like rest of all other lymph nodes till now, even if it is 10 centimeters of lymph nodes also, in my experience, we have tackled it only with medications.
Because there was a paper saying more than 3 centimeter, go for it, fistulas, recurrence. So I guess that's not advisable at all.
I won't deny, but in my experience of say such a huge experience, we haven't seen.
Thank you, sir. I would like to give concluding remarks. We could, when we go with an algorithmic approach from a history, a proper physical examination, we could narrow down our diagnosis and go ahead with a tissue diagnosis. And like Sir said, we should always remember about therapeutic drug monitoring when they are non-responders, and also keep iris in mind. Thank you.
Dr. Ruby, I'll just like to add on one thing over here. Sometimes the lymph node, they are very notorious. You know the drugs are appropriate, you have given appropriate steroids, you have given appropriate anti-inflammatories, but still if they are not responding, you have also increased the dose of the lymph nodes, your drugs, dose of the drugs, and still not responding. Probably these would be the choice of lymph nodes, which I may like to just excise it and remove it off. But after a proper sampling, after all the investigations done. So the excision,
yeah. There's also one common thing I would just like to add, that we find patients who come in, where the AFP smear and cultures are negative and gene expert is positive. So in such patients, we would think of a pre-existing, a previous infection also could show such a test report, right?
It is very difficult, the scenario which you have mentioned, as AFB positive, AFB negative can never be gene expert positive. Okay. It is very, very much difficult, you know. Yeah, it can be. I'm so sorry. I take my words back. Yeah, AFB negative, gene expert positive, and culture negative. Okay, yeah. It can be dead bacilli. Yes, cultures are negative over there. So the same case which was been treated, recently treated case, but gene expert positive can be a dead bacilli, a DNA have come up over there and given a gene expert positive over there. That's may not require treatment every time.
So, as Dr. Vikas has mentioned that it can be dead bacilli, you need to confirm with the MGIT and the clinical follow-up of the patient. That is most important.
Very, very important.
Just, to answering the Dr. Ruby's previous question about the surgical excision of lymph node, one of the patients I distinctly remember that she had a lymph node and she wanted to remove the lymph node from cosmetic point of view. So that is one. And one patient I remember is it was a young person having a lymph node due to NTM, Mycobacterium abscessus, which wasn't responding very well to the treatment. So we need to refer the patient for excision. So these two things apart from what Dr. Vikas has mentioned. So with this and elaborative and exhaustive discussion on the lymph node tuberculosis, I come to a conclusion that we have done a very good discussion. I really thank all of my panelists, Dr. Vikas, Dr. Shilpi Dosi, Dr. Abhijit, Kumar, Dr. Joydeep, Ganguly, and Dr. Ruby Joseph. So I really thank you for a wonderful discussion and putting your clinical practice and your insight into today's discussion. So thank you very much. I would also like to thank Dr. N.H. Krishna, Dr. Narayana Pratibha, Dr. Ashish Dubey, Dr. Anil Maske, and at last Dr. Vikas, Dr. Vijay Kumar Chenamchetti. So CCI has been continuing this Thursday webinar since the 2019, and it's really not a simple thing to continue regularly without any pause since last 3 years. So really hats off to CCI for that. And I also like to thank the technical team for the smooth conduct of today's webinar. And at last, this discussion wouldn't have been possible and successful without our audience and without their active participation. So I thank on behalf of CCI and our panelists to our audience. Thank you very much and keep listening to us and keep believing us. Jai Hind. Thank you. Thank you very much.
CCI rocks. Bye.
Yeah.